Recover, perform, excel. What do those words really mean in a world where injury, recovery and performance are forever evolving? It's time to find out with a performance and rehabilitation podcast from Kikko Health. Okay, I'd like to welcome Paul Kelly to the podcast today. As an ex-professional footballer, has been at Blackpool Football Club, Blackburn Rovers, where I spent many a good year with him before he moved on to Manchester City, and now currently working at Liverpool Football Club. And Paul, if you want to give us a bit of an insight into your roles and responsibilities at the moment at Liverpool, that'd be great.
Yeah, thanks, John. Thanks for inviting me. So currently I am head of Academy Physiotherapy at Liverpool Academy. So we generally have around 220 boys from age 6 to 21 within the academy facility. We look after boys from 9 upwards, really. Clinically, I dip in and out of the complex cases. I have a bit of a clinical role with the 21s, with the under 21s. But yeah, it's just working up and down the site with the various physios. We have myself and 7 other full-time physios within the academy. We have about 25 part-time staff. So it's just sort of managing the part-time staff as well. And, you know, we've put an ATMIF on this October and doing the in-service. And we've got some really good staff here, some great docs and some great physios as well. So yeah, I believe it's a good place to work.
No, we've spoke before about what a great sort of great enjoyment you get out of your current role at the moment and how you're enjoying it there. Do you want to give us a little insight into your own journey, Kels, of how you ended up, I guess, choosing physio as a career? Obviously, I know a bit of the backstory, but give the listeners a bit of an insight to that, and then obviously a bit of your pathway through and sort of, we mentioned a couple of the clubs that you've worked at there, and sort of give us a few things over the years that have guided your career, really, for other people who might hope to follow in such a great career that you've had.
I was an apprentice, a YTS footballer at Manchester City from 1986 to 88, maybe 85 to 87. It's a while back. YTS footballer, and basically at the end of the second year of my YTS, I like a lot of young players, I sustained an ACL injury to my left knee. Surgery didn't work on 2 occasions, so generally we can turn an ACL round now in an academy player, because I was under 17 at the time, in probably 6 to 9 months, something like that. We are elongating it a bit more now to get the graft incorporated. But if we say 9 months, so my story was I didn't play for 23 months at a time when it's a critical period in a young player's, obviously you're still within the growth-related phase, and you're starting to make your career at 17 years of age. Certainly back then, there were opportunities to get into first teams. And obviously, I just didn't play for 23 months. I had 3 operations. 2 of them didn't work. The third one did work, but it wasn't a great option at the time. It was pre-bone patella tendon bone, ACLs or hamstring grafts. It was an iliotibial band called a modified Macintosh operation. So it still left me with a really loose knee. So I never basically got back to the same level. I did get a pro contract, so I was a professional at Man City till I was about 21, and then it was obvious that then I couldn't achieve the same level. I needed to start thinking about other options.
So you went on then to sort of look at, like you say, your different options and different career choices that you could make.
Yeah, I mean, I'd had a lot of physio along the way, some good, some bad, but I was at Lillishall for 34 weeks, so that was. Basically, I don't know whether the club were just moving me out of the way, but yeah.
I don't know if that was enough to put you off physio, Kels, let alone become a physio.
Yeah. No, there was a guy down there called Phil Newton and his wife Pauline who were great people and looked after me at the time. And, I obviously wanted, football was my life, was my passion. So I sort of wanted to stay in football if I could, as you could see my career wasn't going to be as a player. I wanted to keep in the football sort of field. So yeah, it seemed like a good decision at the time. And here I am, I'm 30 years qualified next year. So I qualified in '96.
And whereabouts did you study, Kels? I can't remember where.
University of Liverpool.
Right.
So yeah, I commuted across as a Mancunian.
So you've gone full circle back at Liverpool.
Full circle, yeah.
So even I'm learning things from this podcast.
Yeah, for some reason I got 2 offers, one in Leeds, one in Liverpool. And Liverpool was nearer, so I took the Liverpool one. But obviously a chartered physiotherapy course at the time. Not a lot of sports physiotherapy within the course. The course leader was one of the fellows of the CSP at the time, Eileen Thornton.
Right. Yeah.
And it was a small group, 20 odd cohort per year, and Eileen ran it really well, and it was meticulous, and it was a good course. So it was a good grounding. And obviously you did the placements in and around Liverpool, but as is probably still the case now, the sports medicine side of it, or the manual therapy side of it, is all sort of postgraduate. That was the same then.
I mean, look, you talk about the department there at Liverpool, and probably it's worth us looking at how things have changed over time as well at some point in the conversation. But I guess that one of the biggest challenges you might face now from when you and I sort of worked together back at Blackburn was, you just mentioned the number of staff that you have there. 7 full-time physios, did you say? 25 part-time members of staff. So I guess one of the questions that we ask all the guests is, what are the biggest challenges that you're facing in your work right now? But I would imagine, listening to that in itself, managing that number of people, brings its own challenges.
Absolutely. Different characters, different stages of careers. People want different things out of their role. Yeah, I mean, we have a lot of Liverpool sort of fans here who basically, love the club unbelievably, and this is their life, which is really good. But sometimes it's good to be able to step back, and not as a fan, and just look at things with sort of those spectacles on. So it's like managing any group of people, really, that ups and downs, and get to know your staff. I mean, I've been managed well in some places, not so well in others, and I've sort of picked up along the way. I did again for my own sort of development. I did a sporting directors masters 4 or 5 years ago, and that was good to sort of obviously got the qualification, but it was good to reaffirm that some of the things are the way I manage, people, seems to work. And it's that was good. And it was good, it's when it was like going to a conference. And I always think, if you come away from a conference, I mean, we went over to Madrid recently for the Isokinetic conference, myself and Doc here. And it's basically, we came away thinking, there's not massive amounts, we're not far off. So you think, well, we must be doing something, we must be going okay. Obviously there are bits and pieces, but nothing drastic. So that's always good. So
I always think the same, mate. I always think the same. When you go to these conferences, and obviously I appreciate it sort of bringing, current research, new research to the fore, if you like. But if you come away with 1 or 2 little bits, and then the rest of it is reassuring you that you're on the right path and doing the right thing, that's worthwhile in itself, isn't it?
It is.
I mean, obviously you mentioned there, and we talk about challenges in this sort of section, really, about how have you found, you talked about then sort of some of the sports medicine and the advances that have been made over the last 30 years or so just weren't in place. How do you feel now with the amount of technology that's involved in sort of particularly in the rehab process, or objective markers, or the bits that we bring in? How do you think that's changed over time, I guess, and how have you been with that as it's gone? And I guess the second part of that question is, do you think we've gone too far?
Yeah, I mean, we're fortunate here that I've got access to, or we've got access to, pretty much everything. So your Kangatex, your IKD, bloods, this, that, and the other. Whatever. The club support us really well. I do see in a lot of the younger physios, maybe that, or for me, I always think, get your basics right. And if you get your basics right, everything can work off from that, rather than going straight for the high tariff stuff. Even something as basic as get your knee to walls right, get your handheld dyno stuff right, hand position, get the same person doing it so that your data is reliable and robust at the basic level. And then the other stuff can come in as an adjunct later on. So I just think, it's not a problem, but I just think people generally, or sometimes younger physios, they look for, the Kangatex scores before doing something more basic, and get the basic stuff done first. Your range of movement, make sure your range of movement's good, make sure your power's good. Then we move on to the the Kangatech stuff. So it's we use it here as an adjunct, but we're constantly on about just get the basics right. That's with any injury and any rehab.
I can't remember who it was recently. I read something recently, just again, a social media post from someone just talking about, clinical nous. And I always talk about it myself in a sense of just having a feel. And I think, like you say, sometimes that does come with the experience, but I think sometimes, I don't know, with all the tech, do we detract from the feel? And sometimes with your experience as well, you'll have that read or you'll sense that something's not quite normal.
I'll tell you, John, where we've worked, I've still got my Leon Chato muscle energy technique book that we were using 20 years ago.
We'll have it's under this desk that we're on right now.
Right. None of my physios, the younger people or the part-time people, generally it's gone out of fashion. But I still use those muscle energy techniques, and you're right. Again, it's because of where we're at, and I mean, certainly we are fortunate from an imaging point of view and in professional football as a whole now, I think we're losing clinical assessment skills because everyone gets a scan in the Premier League. And we're fortunate. And I'm sure people in League One, League Two, up and down the country would want the same facility. So I think everyone now, managers want scan results, players want scan results, agents want scan results, parents, it's all about scans. So we have to be careful as a group that you say, so the feel of something. I mean, Leon Chato talks about bind. How does a muscle move? Your active knee extension, how does that feel? We've got to be careful, I think, as a group of practitioners, that we aren't losing that. I think we are in a lot of instances.
I guess as a leader of a department there, and we talk about the number of staff that you manage, I'll let you answer the question first, and then I'll sort of share how I'd sort of have dealt with it or still deal with it now. With how do we try and get that into our younger, clinicians and things? How do you go about as sort of a leader with the younger staff of developing that aspect of the field?
Yeah, I mean, it's just sort of the ethos of the department. The department I walked into was a high level department. Andy Renshaw had moved up to the first team, and I was brought in to take over head physio at the academy. So it was a high level department, really well functioning when I got here. So it's not a bigger problem. We've just got to guide people and say, this is how we do it. This is what we want as a department. And for me, as sort of a manager of the staff, it's just, get hands on. That's how I practice, and invariably, it's more. We don't have that many sort of newly qualified physios. 1 or 2 years out of uni. We generally are fortunate, or we're able to employ people with a bit more experience. So it's definitely one of the things I look for. We've just gone through a process of interviews, and I want hands-on therapists. And I like, they've got access to this, that, and the other. I can teach someone how to use the Kangatech, or we can get the Kangatech lads in a weekend, but clinical reasoning to assess a joint in a certain way, that takes years, in my opinion.
I agree with it, and I've tended to now. I think even going back to our days at Blackburn, I think I remember obviously with Phil Batty as the doc there, ultrasound scanning or MRI scanning was becoming, so everyone was getting scanned in some way, and I felt even at that point years ago we were edging away from it. So I always started playing the game myself, where you'd go, well, particularly when BAMIC came in, sort of mid 2014, 2015, and guess the result of the scan. From my clinical assessment, I think this is this grade of injury in this bit of the muscle, and it's affecting this, and then see how close you were. And I think that's sort of always stood me and sort of my staff going, all right, we're going to scan it, but what do you think it is? What's the scan going to come back with? Just to try and not lose that feel, that, clinical reasoning bit from your assessment and what you're predicting this scan is going to say. And I always found that like a bit of fun, if someone was miles off it, I go, right, we need to get you more experience of training. But it was good and reassuring to them if they were looking at it going, All right, yeah. Actually, I was spot on with that one, or I was pretty close. And I think that's always nice to sort of keep that bit of it, keep that bit of it going. But look, we talked about different tools, and you've mentioned a couple of bits there. Over the years, like you say, you've seen, you know, sort of different bits of equipment come and go. You've seen some hang around and stay. What do you find have been the bits that you've found really sort of, you know, we talk about getting the basics right and, you know, the clinical bits right and the assessment right. What do you feel I guess the tools that you've used along the way, you know, what do you think are the ones that have really worked for you over time?
Obviously, I'm a big IKD fan. So from my education, obviously with Dave Fever and that. So yeah, we've got access to IKD, so I do a lot of that. Has a lot of positives, has a lot of negatives. What we try and create here is I mean, most clubs are doing it, is a pathway. So we would test people from under 14, under 15, and hopefully when they're in our first team at 19 years of age, that we've got all that data in place. So it's not a question of one for me being that much better than anything else. That most of them are pretty much strength measures.
So what sort of things then, Kels? Can you just go into a bit of detail? Obviously, there's such a broad range, and some people that have been listening probably won't necessarily work or have access to the fantastic clubs that you've been involved with. What sort of things would a young player get tested? Would that be different to an older player, or?
Yeah, I mean, look, we don't we IKD from sort of 15 up. That sort of stuff. But the go back to the basics type of stuff. It's stuff, something like knee to wall, your squeezes with a SVIG. You know, we can isolate it in various different ways, but it's squeeze scores, active knee extension with a basic coney, that type of stuff. Yeah, the players in the academy, the younger age groups, get screened on the Monday after the game, for that type of stuff. Don't go over the top on screening too much till the sort of get to the sort of 15s and 16s, because obviously we need to make decisions then on scholarships and things like that. So again, keep it nice and basic. We don't throw the younger players on IKDs or anything like that. But one of the things we do try and do is we call it the core continuum. So we were finding that boys were getting to 15, 16, 17 years of age and basically becoming full-time pros and had really poor control, lumbar pelvic control and that type of stuff. Couldn't dissociate movements, patterns and this and that. So we try from a young age to put this core continuum, which is 7 or 8 exercises that they work through, hopefully to gain this control so that when they've going through or coming out the other side of the peak height, the growth stuff, then they've got some sort of control. Because we were finding that they were struggling bridging at under 16, under 17, under 18, and yet next minute they're training with under 21 players, 13, 14
superstars.
Yeah, I mean we don't the screening stuff is at the younger age groups quite basic. We get more serious about it at 15, 16 level, and we're hoping that will carry them through from under 15. And they're playing with the first team at 21. And like I say, if your data going in is of the right quality and it's not rushed, and we try and standardize it up and down on the academy, that helps so we can see progression.
Because we're from a generation where the FA musculoskeletal evaluation form was there with, you know, millions of measurements, particularly in the academy setting, which is obviously, you know, your focus at the moment. But you know, that was there, and so much information generated and research papers off the back of that. But you know, it's interesting to see, given, like you say, the support that you have from a financial point of view to have the equipment that you need, to what you still find sort of the most solid and reliable, if you like, aspects of monitoring these athletes as they develop. It's because probably people out there think it's probably more magical and more weird and wonderful than that potentially.
Well, up until under 15 level, most of our children are still at school, so we get them from, you know, we get them from sort of 4:30, 5 o'clock in an evening till 7:30. So you're competing with coaches want them on the grass. There's a big competition. We've got to feed them. We've got to make sure we feed them post training, or we try and from a nutrition point of view, which is massive. We're finding we knew about, but we're constantly trying to get them to eat more and get more calories in them from a growth perspective. So yeah, there's always competition for that time, and it's a healthy competition, but we only get a certain amount of time with them because the careers, and the coach's argument is the careers are made on the pitch, and they're probably right.
Yeah, no, it's fair. I guess we just have to try and figure out how the best way, hopefully, to keep them on the pitch.
Yeah, absolutely. Yeah.
And if we can work through that in a front end, preventative, prophylactic, injury prevention, whatever you want to call it, that probably makes our job easier from the rehab side, then, doesn't it? Hopefully, we get less numbers in that sense. So, I guess with it, like we mentioned, along through loads of things will have come and gone. I guess so. It's to talk about this little section, sort of myth or method. Is there any method in some of the madness of the things that go on? Obviously, lots of new things always enter the market. What that maybe haven't been around, or they probably have been around for a while, or they've been in and out. Is there any sort of things that are probably a bit more niche, maybe, that you've experimented with, or you've thought was good, or worked well, or didn't work so well?
I mean, I remember the old power plates coming in.
Yeah,
where a certain club had them
training
outside the dressing room on the way out to play. So anyway, and yeah, I didn't. I think, did we get them at Blackburn, or I think we had a couple, and they soon got thrown out, or I didn't get that.
I don't know what ever happened to those, because I think you still see them in gyms and stuff, don't you?
Yeah, I mean, it was early pre-act, wasn't it? It was an early form of pre-act, and I didn't get that. I did not, still don't. So,
do you know what? I'd kind of forgotten about that as an entity, and I guess like things like BFR had sort of drifted in and then drifted out a little bit, and that seems to have made a much stronger comeback in recent years and months. Why do you think that is? Why do you think that's sort of something that I think it?
We're constantly looking for that extra. We're fortunate enough financially, we can go for it. Most things, we're all looking for those extra bits. But like I say, my mindset is that's great. Get the basics right, get the acute care right. Before we start. If that's in place, then everything else will fall on from that. But the problem we have with football is that, in my opinion, is there's a lot of case studies out there. It's a sample size of one. So there's not a lot of RCTs out there for these things in our cohort.
Yeah, do you find that difficult? Obviously, you're trying to, lead the way at one of the biggest clubs in the world and provide that, right support or right environment for them to do things. Like I say, there'll be pressure to try different things, but a lot of the research might not be in your specific area. Is that a real difficult thing then to integrate things into practice?
It is, but I mean, we're mega fortunate. We have a data analysis department, so we can throw it their way and say, right, what are your thoughts on this? But no, we use our clinical reasoning, and we sit down as an MDT with our medics, and if something's out there, then we will try it. But then somewhere along the line, we hope to see the RCTs come out, and it doesn't always happen. And like I say, so if we put, like the blood flow restriction sort of stuff, we've got players using it now, but it's a sample size of 1 or 2, so they'll get stronger anyway in our cohort because they're young, fit men. Generally, strength is not an issue for these players. It's all the other stuff, the ranges of movement, the load management, growth is a massive issue within academies. So strength on its own is not particularly an issue, and even the post-op stuff, when we use the BFR for that, they hypertrophy very quickly, and we generally, because of the cohort we're working with, the young fit men or boys.
Yeah, and like you say, I guess the potential for their athletic development and their athletic ability in the first place has possibly got them this far. Obviously, with their ability and skill acquisition to be able to play football in the first place, something I wasn't blessed with anywhere near as well as you were, Paul. But yeah, yeah, you're probably right. We're trying some of these things out on the fittest parts of that population and age group. So would they get there on their own anyway? And
they will heal quickly. The strength is not an issue in an academy, boys, in my opinion.
Okay, with that in mind, then obviously with the guys, the fluctuations within the season, like obviously, do you find, obviously you've had great experience in both, men's first team and academy football. As the players go through the season, like particularly so through pre-season, is things like load management and managing the athletes any different in an academy setting as it is to a first team environment? When they're going through, does pre-season differ in any way, or is it pretty similar?
The actual pre-season sort of number of training days slightly differs, but I sort of have a theory that generally most people do a 6-week pre-season, and so my maths, 6 7s are 42. You give them a day off a week. There are probably 35 training days in a full pre-season. So if players can, I tell these players, if you can get through 90% of that 35 days, that will set you up, in my opinion, for the start of the season. So that's how it worked in my mind, and the coaches understand that. So there is a big difference between under 18s training and under 21s training.
In what sense? Intensity wise?
Intensity, everything. Because generally under 21, so if we start at the beginning, that the average age of most Premier League under 18 teams is 16.4, something like that. The average age of most under 21 teams in the Premier League is 18 point something. So they're not necessarily under 21 teams. But to go from, if they make the jump from under 15 to a full-time scholar, big jump in intensity, volume, everything. Then there's a jump again to if they train or play for the under 18s, there's a big jump there. To train from the under 18s, so to play from the under 18s to train with the 21s, again, big jump in intensity and volume. Not so much volume, intensity definitely. And then to play for the under 21s, again, big jump in intensity. That's before you've even looked at maybe hopefully one or two of them training with the first team. So there's these constant increments that we have to be aware of. And yeah, we in some ways we're the Grim Reaper, but I've always thought of part of our role is sometimes we have to be the brake, because invariably these injuries these boys or even children get, they're not days, or most of your growth related stuff or your stress responses, it's months and months. So from a development perspective, which we are, and an academy has to be all about development, whereas a first team has to be about performance. So there's that constant, not battle, but
I guess a balance between.
We have to find a balance, and yeah, and the communication here between up and down 18, up and down the academy is really good, and the communication with the first team is good. So we can send. I mean, they've took some boys away with them, and we can have an input on what we feel how they should be managed. And yeah, invariably that gets listened to. And because we know that these boys that have gone with them that are 16, 17, they're still they're skeletally immature. So I don't believe these boys become skeletally mature until they're 21, 22. But if they're good, I mean, you go back to the biggest names around, go back to everyone's talking about Steven Gerrard here. Steven Gerrard had a lot of injury problems in his early part of his career when he was 19 in the first team, because he's playing against men. And that intensity, and, you need to be really careful with it. And we don't always get it right.
And to be fair, there was probably less emphasis in those days on a lot of the, I guess, medical sports science aspect that we have currently in elite environments. There was. It was
if you're good enough, you're old enough. That's what the mantra was then.
Yeah, and I'm not saying it wasn't exceptional like for that time. Do you know what I mean? And the guys there, provided the highest possible, level of service to their players. It's just, times change, don't they, and evolve. But you talk about, Paul, you talk about there about the environment that you're in at the moment, and it sounds like a really, positive, good communication, good interaction. Now, look, you know as well as I do, and we've all been around the block. Without naming names, you must have a couple of good stories where things haven't quite been like that, and things haven't quite gone that way. Have you ever found yourself in any sort of funny situations where you're thinking, I can't believe I'm in the middle of this conversation, or I can't believe that just happened?
I'm sure I have. I can't really remember, John, to be honest.
I remember ones where I've had a fitness coach take over from me treating somebody on the bed because they felt I was interfering in their performance work on the grass. So comical days, but no, I mean, look, the reality is, it sounds like obviously you've been there. I think you mentioned before, was it coming up to 9 years at Liverpool now?
Yeah, 9 years in September. Yeah.
Yeah. So, I mean, obviously you've managed to shape that environment into an outstanding sort of environment for.
Yeah, the club have supported us really well. We were in a porter cabin to start with, and now obviously we're in the AXA. The under 21s are in the AXA. So, and the club have supported us really well, and we are just about to redevelop our academy, our main academy building. So that's exciting. Yeah, there's some big developments, and why not? Because the academy has certainly functioned well. Not just, I mean, I've been here 9 years, but the amount of players that they've produced, or even up and down the leagues, League One, League Two, the players that we've sold, there's hundreds of millions of pounds there. So it's definitely functioned really well.
Part of the podcast as well is a question gets passed forward from previous guests, and we give them an insight who the next guest is going to be, if you like. So it seems, given what we've discussed, we may have touched upon a lot of these topics already, but it was trying to say, obviously, because of the experience you have in the different environments, what's the main differences you've found between the first team environment and the academy environment?
I think you'd have to split it up into under 15 years and under. I think the one of the biggest point there, it's not a problem. It's just the way it is, that we have to manage parents' expectations. Maybe it's because of the internet or whatever, the information that's out there. But you're not just treating the child. You're managing and looking after the parents as well. So that's a challenge at under 15 years and under, if you like. The older stuff is managing load and getting that right. Because, like I say, if we get a stress response, a pubic stress response, or a pars stress response, or something like that, it's not weeks; it's invariably months and months. So you're taking that they've only got a certain amount of time to develop, and obviously they can't develop if they sat on one of our plinths in the treatment room.
Do you find that one of the biggest differences then, Kels, between the types of injuries that you would get in an academy?
Yeah, definitely. And just going back to the question that you asked, the difference between first team, we have time. We have time because we like I say, our thing is development, not performance. Yes, but they can't perform if they get these growth related stuff. Like I say, they miss big chunks of the development. So that's the difference. First team is, we in the academies, we can respect healing times, whereas in the first team, it's like you're working back from a game, potentially. What games are you ready for? And you're thinking, well, that's the inflammatory process won't have, gone through its full course by the time you're wanting him to play or start a game. But that's when you get your MDT together and you go, right, are we happy as a team? We move forward together. Anyone got any issues? Speak now, or else if we decide as a team to go with it, we go with it.
Do you think that's an easier conversation, like you say, in an academy setting as opposed to a first team environment?
Yeah, definitely.
Because I presume there's still the same pressures there you might have a couple of good players in the academy that you might have as an important game, or the coaches would want. I would imagine that there's still an element of pressure there for you to deal with.
The whole aim of our academy is to get players into our first team. That's the main aim. That's from day one. That is what we're all told. We develop these players, get them ready. So that's how we sort of manage things lower down, is, well, basically, okay, we want that under 16 player to be ready, or under 15 player for this game or your semi-final that's coming up. But really, if we're not happy, then the overall aim is to see if he can get in our first team when he's 19 and become the next Trent or become the next Curtis Jones. or become the next Conor Bradley, or there's a line of them. So that's where, what we do at 16 is important, and they have to develop. Keep them on the grass as much as we can to give them the most time to develop. But really, the bigger picture is, can we get them in the first team?
I guess then, look, the final part, again, a lot of the questions that you've gone through and answered there as we've gone along is, what would be your one piece of advice for sort of young practitioners coming into the profession of physiotherapy or coming into elite sport? What one or two things would you sort of say to them going, look, this is the most important thing you need to focus on?
I mean, it's patient mileage. So if I'm a young practitioner now coming out of uni, get your hands on. So go and join. My first, when I was in a third year at Liverpool, when I was driving home 2 nights of the week, I would go and be a part-time physio for Winsford United. So I'd drive across from Liverpool on a Tuesday and a Thursday, and then do the game in I think it was the Unibond Prem at the time, for 20 quid. But it got me hands on, and it got me working with players, and I could make mistakes, and it's patient mileage. The more you see, the more you learn, and we're still learning. I feel I'm still learning now. You see stuff every other day, and it's like, wow, well, where's that come from? Or that presentation, I've not seen that before. Or that's the good thing. It's probably because we've still got so far to go to feel like we've cracked things. It's the way it is. But I find it really every day you're learning.
We spoke beforehand, between us, we've been in football 55 years.
Wow. Yeah.
As physios,
John.
As physios, between us, we've got a bit of patient mileage. But you mentioned one thing there, Kels, which was making mistakes.
Yeah.
And I think a lot of the time people worry or fear, making a mistake, maybe. How do you feel about that? I think it's an important thing. Obviously, we don't want mistakes.
I just think mistake, I might have used the wrong terminology or the wrong word. I've set rehabs up, and I mean, an analogy I'll give you, and it was, again, our mate Dave Fever. I remember him telling me about soleus injuries. Once you think you've got a soleus right, give it an extra 4 or 5 days. Because the number of soleuses we've all been bitten by, where you think you clear them, you're hop testing, you're this, you're whatever you want to do, objective markers, you clear them, give them a few extra days. And there's no rhyme and reason about that, apart from the tissue that you're trying to get to heal, the function of the muscle, what it tries to, what its function is. And all our experience is just give it an extra couple of days if you can. Because soleus, the number of recurrences with the soleus injury, I'm
laughing because you're right.
So something like that, that's patient mileage and experience. So you have to break a few people down in the nicest possible way to step back and go, right, reflect on that. What would I have done differently? And hopefully the next one goes. And generally you get to a point where you get most of them right. But still, you get the odd one that catches you. And again, you just step back and you reflect, and as we do as an MDT, and you move forward. So there's not a mistake. It's just we tried to push in a certain way and it's not worked.
Yeah, no, and like you say, mistake might not be quite the right word, might it? But I think sometimes learning from things that don't quite go to plan is sometimes the best learning that you can have. But I think you've picked probably the greatest problematic injury of all time, where we've all been bitten. So no, like I couldn't agree more. Well, look, Kels, like I say, thanks ever so much for joining us today and giving us some insights into the world of Liverpool Football Club, and obviously operating at the highest level as you have done for the last 30 years, and many more to come, with everything that you talk about with Liverpool. And I can sense the enjoyment that you have of being there and the environment that you're working in. So that's fantastic to see as well. But no, amazing. Thanks ever so much for giving us the insights you've given us today, and much appreciated. Thanks, Kels.
Oh, that's fine, John. Thanks for inviting me.
So that's it for this episode of Recover, Perform, Excel. Thank you for listening. If you took something useful from today's conversation, share it with your team. your colleagues, or anyone on the rehab and performance journey. You can subscribe and find all episodes on Spotify, Apple Podcasts, and at kikkohealth.com. And if you've got a myth to bust or a method to share, reach out. We'd love to hear from you. So until next time, keep moving forward.